Good morning, everyone. We're going to get started. We've got a full day today. Welcome to the Wilson Center. My name is Sarah Barnes, and I lead the Maternal Health Initiative here at the center. For those of you who are not familiar with the Woodrow Wilson Center, we are the living memorial to President Woodrow Wilson, who remains the only president to have received his PhD. The Maternal Health Initiative itself is focused on ending preventable maternal mortality in navigating gender-based health issues through independent research, open dialogue like we have here today, and actionable ideas. Today's event with JSI Research and Training Institute, Inc. and FHI 360 is focused on the importance of community health systems is central to MHI's mission. Since 2012, the USAID-funded Advancing Partners and Communities APC project has worked in 40 countries to improve community health systems with a particular focus on family planning and infectious disease prevention. We'll be talking about all of these issues today through our two panels. So today we're really here to discuss successes and challenges APC has faced, lessons learned, and next steps. Thank you to all of our panelists who are here today. I know many of you have traveled very far to be here, so welcome to the Wilson Center. A special thank you also to Katie Cook, Liz Creel, and Anne-Marie Vid from APC and JSI, and Amanda King from MHI for all of your hard work making this event happen today. So today's event, as many of you have hopefully seen through the beautiful brochure that's out in the entryway, has two panels. So the first panel is focused on promoting family planning and power of partnerships. The second panel will discuss advancing local solutions for lasting impact. We'll have a very short break in between the two panels and a reception directly following the second panel where you will be able to continue your conversations with all of the panelists during that time. There will also be a question and answer period for each distinct panel. And for those of you watching online, please submit questions to @Wilson_MHI, and we will get those to the moderators. And now I would like to turn the event over to Liz Creel, who will start us off with some opening remarks. Liz is the project director of APC at JSI Research and Training Institute, Inc. Liz leads APC and has over 25 years experience in family planning, reproductive health, maternal newborn child health, and environmental health. It's a pleasure to have you here, Liz. Please come to the stage. And Liz's bios and everyone else's are also available outside the room. Thank you.
Good morning. It's a pleasure to see everyone here today. Lots of familiar faces and some new ones as well. Thanks so much for joining us. Before I begin, I'd like to thank the Wilson Center for hosting our event, USAID for their support of Advancing Partners and Communities, commonly known as APC, the dedicated and talented APC team from JSI and our partner FHI 360, and the project's many partners in multiple countries for all of their efforts to advance community health. As background, and Sarah noted some of this, APC is a 7-year USAID-funded community health project that has strengthened health services in more than 40 countries, from the most remote communities to national ministries of health, with a particular focus on voluntary family planning, infectious disease prevention, including HIV and the post-Ebola response in West Africa. We have also supported vulnerable populations, from people with disabilities in Laos to women and their families in Haiti, seeking financial services to become more self-reliant and free from poverty. In my time and travel with APC, I have been struck many, many times by the power of communities at multiple levels. One definition of community is a feeling of fellowship with others as a result of sharing common attitudes, interests, and goals. I am very proud to have served with the APC Fellowship to advance community health in the countries where we worked. Since 2012, APC has served as a flexible, multidisciplinary vehicle that's brought in different technical sectors that have helped inform one another and create a more comprehensive approach that has strengthened health services more broadly and helped countries on their path on the journey to self-reliance. We launched this project at a time when attention to the critical role of community health was increasing. At the same time, there was an increased recognition that so much of the community health system was fragmented in terms of programming, information, and policies. This all gave APC opportunities to support harmonization for community health at the global level, which you will hear more about later in the panel. At the heart of APC is our work with community health workers. They are a critical component of the healthcare workforce, as we've seen through our activities in community-based family planning, the post-Ebola response, and with vulnerable and underserved populations more generally. Today, you will learn more from our panelists about APC's work to provide community-based family planning to communities in Benin, Uganda, and Kenya, as well as several examples of our efforts to build the capacity of local organizations in Haiti, Liberia, and Laos. In addition to what you're going to hear from the first panel on family planning, I'd like to highlight some of APC's work in this area. In 21 countries, APC strengthened family planning by training health workers, building capacity within local NGOs, advocating for policy change, and introducing new methods desired by clients. The project reached almost 240,000 new family planning users, gave 370,000 community members information about a wide range of family planning methods, and trained over 11,000 health workers to deliver quality counseling on family planning. A second area that I'd like to highlight is APC's work in capacity building through the provision of grants in lots of different forms and sizes that included flexible amounts of targeted funding to help local and international NGOs reach underserved and vulnerable populations. All told, APC awarded 110 grants to local and international NGOs in 31 countries. For nearly 60 years, USAID has made it a priority to help support the growth, development, and independence of local organizations. Also, one of the founding principles of my organization, JSI, and the Advancing Partners and Communities Project has been a part of that journey to self-reliance. At this time, I'd like to introduce you to Ellen Starbird, the director of USAID's Office of Population and Reproductive Health. Ellen is not new to anyone here, but I'd like to share a few thoughts about her. Throughout her long career at USAID, she has been a champion for family planning and reproductive health with more than 25 years of experience designing, managing, monitoring, and evaluating programming in this area. She has also been a mentor and a strong friend to many in the larger global health and development community. Ellen will be introducing our first panel and will serve as the moderator. And now I'll turn things over to Ellen. Thanks so much.
Thank you, Liz, and good morning, everyone, and welcome to those of you who are joining us remotely. It's great to have everyone here. USAID's priority is to end the need for foreign assistance, and to achieve this goal, the agency focuses on the journey to self-reliance, defined as working in partnership with countries to assist them in planning, financing, implementing, and evaluating solutions to their own development challenges. This panel on promoting family planning and the power of partnerships demonstrates how USAID's family planning program and the Advancing Partners and Communities Project are working together to strengthen community health systems for family planning and to support countries on the journey to self-reliance, improving open and accountable governance, inclusive development, and building the capacity of governments, local organizations, and citizens to address family planning and improve health outcomes. Enabling couples to determine whether and when to have children and how many children to have is vital to safe motherhood and healthy families. Our programs help individuals make a free and informed choice about their use of family planning by providing access to and information about a variety of family planning options, from natural family planning to short-acting methods to long-acting reversible methods and voluntary permanent methods. Advancing family planning and reproductive health also plays a critical role in promoting global health, supporting global stability, addressing humanitarian crises, catalyzing innovation and partnership, and empowering women and girls, all contributing to improved self-reliance. One way we're doing this is to improve method choice at the community level and build both the capacity and commitment of countries to strengthen community health systems. USAID has a long history, as Liz noted, of supporting local and community-based organizations and recognizes that capacity building of these organizations is a critical part of contributing to a vibrant civil society, one of many aspects measured in the country roadmaps for the journey to self-reliance. PRH has supported, the Office of Population and Reproductive Health, has supported local capacity building for at least 15 years through the Flex Fund, the Grant Solicitation and Management Award, and now the Advancing Partners and Communities Project. I want to thank the management team and the implementing team at APC, as well as the folks in the Office of Population who have provided leadership and guidance to these awards over time, including Victoria Graham, Maggie Farrell, and Melissa Freeman. Missions have bought into these mechanisms in addition to having programs of their own through their bilaterals. And these programs have brought new partners into the USAID orbit and strengthened relationships, often between long-standing USAID recipients and newer partners. We have lessons from these programs that you'll hear about today that are relevant as the agency pursues even more robust partnering with local organizations. USAID programming creates access in hard-to-reach places. Community health systems and community health workers are often the first point of contact for many women in low and middle income countries. And they address a gap in service delivery that provides products and services, information at the last mile to underserved populations. We help to ensure that in-country policies become more favorable for these lower-level providers who are administering community-level family planning care, thereby relieving the burden on overworked health providers at health facilities. And our partnership with APC has been instrumental in supporting these types of models. With APC's help, we're generating country-specific evidence, conducting workshops with national stakeholders, and supporting opportunities for South-to-South learning. These activities create policy change and directly address authorization for programming at national scale. Through partnerships with organizations and projects like APC, we've laid the groundwork for programs that focus on human-centered design, a research utilization framework, and strategies to ensure buy-in from local actors. Partnering with decision makers from governments, donors, and implementing partners to help sustain family planning services beyond the life of any particular project is the goal. So I want to turn now to introducing the panelists who are going to do little 5-minute TED Talks. I think you'll find them very engaging and informative about the kind of work that APC has been doing. So I'm going to introduce each speaker as they speak, beginning with Jean Afo. For the past 6 years, Jean Afo has served as Chief of Party for APC in Benin. Mr. Afo has more than 25 years of experience managing community health programs in Benin and in West and Central Africa more broadly, specializing in reproductive health, family planning, maternal and child health, HIV/AIDS, and health communication.
Thank you. Hello, everyone. Yeah. Good morning.
Good morning.
Yeah. I'm honored to be here today to tell my story. My sister, who is 3 years younger than me, was married at age 15. During her life, she and her husband have 8 children, and the first 4 never went to school. Her husband not believe in adopting family planning methods to space their children's births. My sister was already a grandmother when she had her 7th child at the age of 30. The delivery was very difficult and we almost lost her. She decided it was too risky to have more children but could not adopt a family planning method for fear of her husband's reaction. Unfortunately, 4 years later, she became pregnant again. After the birth of her 8th child, my wife, who is a midwife, and I helped to choose a method without her husband's consent. This helped her avoid pregnancy until her death in June 2012. After she died, my wife and I adopted her 4 youngest children. Like my little sister, thousands of women and couples in Benin do not have adequate information on family planning. Traditional attitudes still prevent men from learning how to space their births. For this reason, in 1999, I decided to dedicate my career and my life to promote community health and specifically voluntary family planning. Benin faces high maternal, newborn, and child mortality, poor modern family planning use, and health workers shortage. Nearly half of the population lives in rural areas with limited access to health services. Benin has struggled with a lack of political will around health. Fortunately, things began to change in 2010 when the government introduced a package of strategic health interventions. As APC has been working in Benin since 2013. The project's first assignments were to provide technical assistance to 3 local NGOs funded by USAID to strengthen community health systems and to expand family planning access to an area covering 3 million people. We learned that strengthening community health is critical to expanding voluntary family planning. We must involve religious and community leaders in the conversation. And third, local financing is key to sustainability. APC trained and supported community health workers to deliver basic health services. We work with national and local government and NGOs partners to strengthen supervision, data collection and management, and to involve communities. Strengthening communities' health system enabled Benin to expand voluntary community-based family planning and introduce DMPSC called Sayana Press in Benin to underserved women. As a result, more than 1,000 community health workers were trained on the full range of family planning methods. So, how was this possible in communities where family planning is not always accepted? We found that engaging religious and community leaders is critical. We listen to their concerns and generate excitement for family planning. Now, many leaders speak publicly about the benefits of voluntary family planning. Finally, there is the question of financing for self-reliance. In Benin, mayors are supposed to provide community health funding, but they seldom do. In 2014, when we started, only 2 mayors were putting money toward community health. APC worked with the NGOs and to reduce mayors to educate mayors to develop community health plans and include budgets in the plans. This year, 18 mayors have allocated nearly $100,000 to their 2019 budgets, $100,000. The government is excited about this. In conclusion, Benin has come a long way in the past 20 years to improve health. While there is still much to do, I'm proud and encouraged by Benin's progress and the still dedicated people, particularly those working in communities. I'm honoring my sister's legacy so that her children will have a better life. Thank you for your attention.
Thank you for that personal and very powerful story, and congratulations on the contributions and impact of the work in Benin. Next, we're going to hear from Frederick Mubiru. Frederick is the chief of party for the APC project in Uganda. He has 15 years of experience as a reproductive health and gender programming specialist. Frederick leads a team to implement programs that strengthen government leadership and address sociocultural barriers to family planning at national, subnational, and community levels.
Thank you very much. And good morning, everyone. I'm happy to be here to share with you the work we have been doing in Uganda. So my early career in the reproductive health work was in mostly in northern Uganda, in the northern part of the country, which was conflict affected at the time. And most of the programming at the time was around emergency obstetric care. We couldn't really do family planning. But in 2014, when the APC program launched in Uganda, I had the opportunity to take back to this area a program that was about voluntary family planning in a developmental arena. And over the years, I've seen one of the districts in this region really transform as regards voluntary family planning. And this particular district is called Agago. It's far north, very close to the Sudan. And it was really one of those most affected by the war. And I'll start with a quote from one of the meetings we had earlier in the program with one of the, from one of the participants who said that family planning makes women to behave like young girls and they go out and have fun. I think that tells you what kind of attitudes and norms we were going to confront by 2014. And after 3 years of working in this area, mostly promoting availability of family planning services through community health workers and quality family planning, USAID asked us to kind of shift gear to do business differently, to address the socio-cultural factors that affect the uptake and demand for family planning in these areas, but also to increase, to build ownership for family planning programs. And our first step was to carry out fertility hotspot mapping identification, which was an approach that used secondary data to analyze the country situation and identify where the high fertility hotspots, but also hotspots for high adolescent pregnancy, which is a national issue, were. And following that, then we did a deep dive using the USAID Passages Social Norm Exploration Toolkit to understand the deep-rooted drivers around that. We then worked with the stakeholders within these districts, the local government and USAID, to identify tailored interventions for the areas. So for instance, in the Agago district that I talked about earlier, because there was an issue about male spousal support, we are implementing the Emanzi. Emanzi is simply a role model man, and it's an approach that takes them through a 9-week curriculum that addresses gender issues, but also teaches couple communication and joint decision making. While in another hotspot district, Buyende district in another region, we are working with faith-based leaders in that area to promote family planning through the Christian Family Life Education curriculum. Now, in these districts that were selected were really high above the average in total fertility. So for instance, Agago has the women give birth about 8 children per woman, while the TFR at the national level, the total fertility is about 5.4. So when we changed approach in 2017, in these districts, we started focusing so much on social norm change, and we also addressed the issue of working with the districts to build ownership. And I was so impressed on my last visit to this Agago district when I found that the district, which we found earlier didn't have a lot of ownership and commitment to family planning, was now transformed. The planner in the meeting I was, which was a stakeholder meeting, he said that if a sub-county chief brought their budget without a line for family planning, I will not approve it, because I'm now convinced about the contribution family planning can make to our development. And again, we've increasingly, like I said earlier, worked with faith-based leaders, and we worked with, we had this young man, Mr. Peter Chimbowa, who was involved in a faith-based training curriculum activity, and he felt that he needed to reflect on his resources and the number of children he has, and he realized that he was not going to be able to give them a good life. And he chose to go back, talk to his wife, and they go to a public health facility. They went with the intention of getting a natural family planning method, but after engaging with the health worker, they took away an injectable contraception because they wanted to go with the method. So the success of the program in Uganda has been so much about working in partnerships with the local governments, national level government, using evidence, having tailored and adaptive interventions that address the deep-rooted barriers and social norms. Thank you very much.
Thank you so much, and thank you for highlighting the importance of thinking about culture and tailored solutions, the idea that one size doesn't fit all, and we really need to be attentive to what we're learning from the community about what's going to work best for them. So our third TED Talk speaker is Susan Ocher. Susan is the Senior Technical Advisor at World Vision US. She is a trained and certified nurse midwife and currently leads the planning, development, implementation, and advocacy of projects on healthy timing and spacing of pregnancy and family planning. She's spent her career working on maternal, newborn, child, and reproductive health worldwide.
Thank you, Ellen, and good morning, everyone. I started out as a young Ghanaian nurse midwife in Ghana, and I wanted to save the world. I find myself in the eastern region of Ghana in a rural hospital. Then I got curious and I volunteered to join the National Expanded Program on Immunization. I was in for a real surprise. Well, the experience entailed walking long distances to communities, sometimes having to wear boots to wade through streams because of lack of road access, just to deliver immunization and maternal and child health services. My reward, the smiles and thank yous from the women and the men. Why were they so grateful? Well, the Ministry of Health had brought services to them, to their communities, because someone cared. And that's how I find myself shifting from clinical to community health. So fast forward. Then I came to World Vision and worked on our healthy timing and spacing of pregnancy and family planning programs. That included this integrated project supported by the USAID Advancing Partners and Communities project in 5 communities in Garbatula in Isiolo County, Kenya, with approximately about 40,000 people. Our goal was to improve access and use of voluntary family planning for better maternal and child health outcomes. So here I am, working in a Christian organization, along with my colleagues, teaming up with the Muslim community just to make life better for women, children, and their families. I tell you, I was in for a real, awesome opportunity. But first, let me tell you about Garbatula. Garbatula is in the northeastern part of Kenya. It is predominantly Muslim, very remote, very hot, and very dry. Frankly, it's like a desert. The people are poor, are mainly nomadic pastoralists, moving from one area to another, just in search of pasture and water for their livestock. Remember earlier, I had indicated my first community health experience was in remote Ghana, but it was nothing compared to Garbatula, where health workers and community have had to face gunfire and tribal conflict over like a year and a half as we were implementing the program. Despite these challenges, we did not stop working. World Vision continues to work in Garbatula and in places where typically others do not. And as a Christian organization, we managed to get the trust of the people. So now we can boast of some successes. Firstly, we did our best to understand the community. The people in these communities did not really like the use of the word family planning, but the terminology birth spacing was okay. Why? Because it fits very nicely with the teachings of the Quran about the importance of keeping women healthy by spacing births and also allowing for breastfeeding. So in that of our World Vision's healthy timing and spacing of pregnancy approach to family planning was perfect for these communities and helped us gain the trust of different community groups like men, religious leaders, women's groups, and even teachers. So together we all joined hands and promoted understanding of voluntary family planning and adoption of healthy behaviors. Together, in 2018 alone, we reached nearly 14,000 men and women with messages on birth spacing and family planning. Secondly, we work directly with religious leaders and community leaders to break barriers and understandings about family planning and made them confident to speak about birth spacing and family planning during Islamic teachings and in Quranic schools. In fact, in the past year, our data shows an increase in use and in longer-term methods. Thirdly, in collaboration with the Ministry of Health, we trained community health volunteers and nurses, added to family planning method choice, and integrated family planning into maternal and child health clinic days. This helped reach more women and their husbands. And these are promising practices, you will agree. To close, I have two reflections. In all our efforts, we've heard from the people in the community that the next call to action is to integrate food security into the Garbatula health programs. And personally, I think and I see this as a community's journey to self-reliance. Finally, World Vision through the Advancing Partners and Communities Project is the only organization implementing a birth spacing and family planning project. Together, we brought life-saving services to the people who needed it. And I think that counts as saving the world. I thank you for your attention.
Thank you, Susan, again, for a really powerful story. I think we could all visualize where you were and some of the hardships of working in those kinds of settings. So that concludes the TED Talks, and we're going to move now into some conversation with the panelists, and introduce a fourth participant in that. That is Tanvi Pundit Rajani. And I'm going to pose the first question to Tanvi, but let me tell you a little bit about her first. So she serves as the team lead for community health systems and helps to advance APC's global technical leadership in this area. She's a senior technical advisor, and prior to joining JSI, worked in a variety of roles within USAID, including in the Office of Population and Reproductive Health, as well as other implementing partners to design, manage, and implement programs to strengthen policy and the role of private sector in health systems. So Tanvi, maybe you could talk a little bit about, in your role supporting global technical leadership for the project, what are some of the key approaches that APC has used to strengthen community health systems at a policy and at a program level?
Sure, thanks, Ellen, and good morning, everyone. I think it might be perhaps helpful to start with a little bit of background and context as to what was happening at the start of APC, which was around 2012, 2013. Many of the folks in the room are likely familiar with this, which is, there was an increased recognition about the challenges around fragmentation and community health programming. And there was a recognition that, in particular, activities across community programs were fragmented, metrics weren't standardized, and in fact, even there was weak and perhaps even absent linkages with the formal health system. And very much related to this was lack of cohesive policies that would guide and help align community health programs within countries. And so in response to this, WHO put out a harmonization framework and asked countries, really to help, think through a consolidated, more cohesive one strategy for the country that would help align their programs. And in that call, they also asked that countries involve a range of community health actors in that process. The challenge, however, was that there was a lack of, easily accessible information on what some best practices might be around community health interventions, what the policy inputs would look like. And so what we thought was, at this time, because of this lack of information, perhaps there are two approaches that we could take. One of them was, could we fill the information and data gap for many of these countries? And so one of the things that we set out to do is consolidate the range and breadth of policies related to community health. And I think it's important to perhaps stress that it's not found in one place. This information is across human resource policies, the specific health interventions, whether they're family planning or maternal health or nutrition or even agriculture. We would have to look at even primary health care and pull that information together to help countries really think through what some of those inputs would look like. And so as part of this, as part of this process, we were able to create an online hub that made that information not only accessible, but digestible to countries to help answer questions like, what should be the role of a community health worker? What type of services and products can they provide? What should be the compensation for them, if at all? And how would they be compensated? Is that something that happens at the local level? Is that something that happens through the national level? And some of that information we were able to start pulling together for countries to share. And that also served for us as a springboard to help policy efforts in country, to help design policy, to provide technical assistance. At the same time, countries themselves started to use that information as well, because they were able to see what neighboring countries and regions were doing to help strengthen the policy environment in their respective countries, both local and at national level. And so what we found was there was a huge demand for this information, both globally and at local level. And so this online database was later expanded to include maternal, child health, and nutrition as well. A second area where we were able to sort of innovate and think about approaches at the global level was actually engaging the community actors in policy design. And so at the start of APC, one of the things we were hearing about is human-centered design, an approach that was often used in the private sector to develop new products, new tech products. And it was sort of being toyed with and played around with in the social and public health sector. And so one of the questions we wondered is, could we apply human-centered design to a policy context? And could we use it to help co-create policies with a diverse range of actors in country? And so we worked with a human-centered design firm in 3 countries to engage a range of policy actors or community-based actors that would typically not be invited to the table. We did this first in Tanzania, then in Sierra Leone, and most recently in Zambia. And the range of actors that we involved looked different country to country because the issues were different country to country. So, for example, in Tanzania, one of the first things that they were working on was a very ambitious scale-up plan for community health workers. And that policy and that design had been sort of stuck in the approval process at national level. So what we were able to do is through our technical assistance using a human-centered design approach is we brought in community health workers, clients, district health officials, community health providers in the facilities to help think through solutions that folks weren't actually reaching consensus around. Likewise, we were able to do something similar in Sierra Leone in a post-Ebola context. And there, the issue was different. It was, how do we harmonize and standardize what facility management committees look like? And this was particularly important because facility management committees were important to building trust, as well as improving quality. And in some cases, those management committees were working quite well, and the country really wanted to look at how could we build on what was working well and apply it to those areas where it wasn't working well. And so we helped shape the policies around that. And then most recently, Zambia has brought in a new product, Cyanopress, into their health system, and they're looking to scale up. And what's great about the strategy there is that it does consider a total market approach for scale up, and so that's engaging the private sector in that. However, what that looks like and the policies that are being developed at national level haven't really involved private sector, private providers. So most recently, just last month, we were in country again working from a human-centered design perspective to bring in the private sector into that dialogue. And so together we were able to create some solutions that would help them think through how they would operationalize that.
Thanks so much for adding the global perspective, and I think highlighting how important it is to recognize these linkages between what we can do globally and what we can do locally and how they inform each other. It's not a one-way trip. They really are self-reinforcing. Thanks. Jean, my next question is for you. The APC project in Benin focused quite intentionally on providing technical support to local NGOs instead of funding them directly. Could you talk a little bit about how that came about, how it worked out, and what the challenges or opportunities were that resulted from that approach?
Thank you. From my perspective, I think this approach worked well because APC did not have to manage NGOs grants. We were able to be a technical resources and coordinator to link governments, NGOs, partners, and local leaders. This approach also enables us to be a key partner for USAID. So we were able to respond quickly to their request. The NGO we supported had not previously managed USAID funds for health, and so we had to identify the capacity needs. Priority areas identified includes monitoring and evaluation, data quality assessment and management, work plan development, reporting, and financing management of USAID fund. This was a challenge because NGOs had a short-term period to learn these different areas and begin carry out the work. And to address this, we provided a collaborative environment to NGO where they had the opportunity to learn from each other and engage with the Ministry of Health at all levels.
Right.
Yeah.
Thank you. I think this is such an important lesson for us, particularly as USAID really wants to move towards doing more work at the local level and working with local organizations. Many of these local organizations, I think, have the issues that Jean is talking about of not having been USAID recipients in the past. And so the effort that needs to be put in on the front end to really help those organizations build capacities that are beyond technical are ones that I think we all have to keep in mind as we think about what we can achieve and how long it's going to take to do it. So it's really valuable to have this experience to build on. Thank you for sharing that. Susan, my next question is actually for you. If you could talk some more, you talked about World Vision's approach to engaging religious leaders and men in the dialogue about family planning. Could you talk a little bit more about what the project has learned in that process and how to sustain those gains in the longer term, as well as more about the added value of working with faith-based organizations to advance family planning?
Thank you, Helen. One of the things that we learned in the process is that we needed to come down to the level of the community with and the religious leaders especially, and the men, because most of the religious leaders were men. And so the hook that we got was to focus on birth spacing in the beginning and not family planning. But then the road did lead to voluntary use of family planning, because you can only attain birth spacing through use of a modern method of family planning, which includes natural methods. Ellen, you mentioned that. And we also, it was a long process because we had to use a curriculum. We thought that was the best way of like adult teaching. And so we actually used, World Vision has its own methodology called Channels of Hope. But in this instance, we used the USAID curriculum called Mobilizing Muslim Religious Leaders for Reproductive Health and Family Planning. I think it was part of the Extending Services Delivery Program a while back. So it was, it had similar elements like the World Vision's Channels of Hope methodology. One other thing that we also learned about sustainability, and this is from Garbatula and from our other projects, is that the faith leaders who were on board really wanted to institutionalize some of the lessons in, on a bigger scale. But one thing they told us that in order to do that without fear or without, with more confidence, is that if we could reach out to their leaders at the national level and begin to work with them, then then we could, they could be more, they can do it wildly and freely, and and in actual fact, I thought it was, we thought that it was a great, recommendation, because once you get it at the institutional level, then filters, you get more coverage and much more sustainability in that sense. I think your last question was about the value add of working with faith leaders. I think until recently, the faith community had sort of been left out of the picture, and I think that huge aspect of faith is so important to our work as development partners, especially as we work in family planning and even HIV/AIDS. And I think that the filling that gap of bringing on the faith community will reach a certain group of people in the pie. Because if you read the Lancet series, like 80% of people affiliate to a religion. And so having the faith voice in our work, I think will help us move the needle a little, especially when we are talking about voluntary family planning.
Yeah,
Thank you.
Thank you. So many of the health services in the countries we work in are run and managed by faith organizations, that absolutely engaging them is so important. And I also liked your point about sort of policy with a small p around organizational commitment at various levels to doing this, and how important that is in sending the message all the way down the system that this is something that we want to do. Frederick, you talked a little bit about the fertility hotspot mapping and gave us a couple of examples. Could you say a little bit more about how that works and its relationship to your youth-focused programming?
Thank you. So first, when around 2017, when we were getting the extension for the APC program in Uganda, it's just the same time when USAID was introducing its new strategy in Uganda, the CDS 2.0, and it had all these, guiding principles around collaboration, data-driven, etc. And so we came right at that time, and we were asked to think differently in the way we were going to work in the next phase of the program. And we were even going to select new areas of work and test new interventions. So we looked for an approach, and we engaged the Makerere School of Public Health, and we started brainstorming. And what the idea we came up with was the fertility hotspot mapping identification. This has been used in the HIV/AIDS world before, but for family planning, it meant that we were going to use existing data within the datasets that we already had in the country, because the guys we worked with at Makerere School of Public Health were already the same people doing the PMA 2020 studies. And again, they were somewhat involved in the national census of 2014, and they knew that the census had been powered to measure total fertility this time. As well, we had a lot of other data, the recent DHS, and then the DHIS2 has also been strengthened of late in Uganda through several partner efforts. So we really just did an analysis of existing data, and then we made sure that one of the key variables we were looking at was the age of sexual debut for the young people, but also pregnancy among the young people. And so the study, of course, identified the areas that were hotspots for this, and that's where we went to intervene. So we didn't choose where we wanted to work because we were friends with the district or that kind of thing, but we went there because that's where the interventions were most needed. And then in there, we engaged the stakeholders that we wanted to work with, the target beneficiaries, through other approaches like the social norm exploration that I mentioned about. And again, we used experience-based co-design, just like to work with the target groups to identify which interventions would work for them. So for instance, we had never set out to do something around parenting in our programs. In my entire family planning work, I'd never thought about that. But the social norm exploration showed that the young people were saying, they will say their colleagues are getting pregnant. They don't say myself. My colleagues are getting pregnant because their parents don't care about them. They don't tell them what to do. And the community is also blaming the parents. So we're like, the parents is an issue. I think we need to do something. Then you engage with the parents. What can we do? How can we help you? The young people, what do you want the parent to help? And then you come up with kind of a format for a dialogue between the groups. So that is what guided our youth programming. So following that, we've then developed we worked again with these same stakeholders, come up with a package of interventions which are tailored again to the different areas, as relevant as it would be. Because, for instance, in some of the districts, there is no strong cultural institution, while in others there is. So where there is a strong culture institution, we worked with it and we anchored the parenting intervention there. Where it wasn't, we did something else. Maybe we were doing adolescent girls and young women, some kind of mentoring program. So yeah, that is how we've worked in this arena. The other thing we did that is critical and in line with the power of partnerships is identifying local organizations and subgranting them with as little as maybe $15,000, $20,000 to try out interventions around prevention of adolescent pregnancy at the local level. And we have seen really interesting results from some of them. Thank you very much.
Great, thank you. Thanks so much. I think, again, it's sort of the range of partnerships that this suggests, from formal organizations to community partnerships to parents, and all of those folks have a role to play. Dr. Alma Golden, who is the administration's nominee to be the assistant administrator for the Bureau for Global Health, likes to talk about preparing youth for partnering and parenting, and the importance of the engagement of their parents in that process, and how there are opportunities when working with youth to really affect 3 generations, both the youth themselves and the actions that they take, their ability to be parents, and then what the lives of their children look like when they choose to have them. So I think the kind of thing you're talking about really going to the community, hearing from the community about what they want, where they see their own challenges to be in, working from that is so, so important. Thank you for that. So I have 2 more questions. These don't have particular respondents, but rather I hope that we can have a bit of a conversation among the 4 of you as the panelists, and maybe spend about 10 minutes on each one. So the first question I have is, we know that APC has done a lot of advocacy around expanding access to family planning, and I wonder if each of you could talk a bit about your role in that and your experience with that in your country. And is there someone who'd like to go first? And we can bring in the global level as well.
Okay.
Please.
Yeah, thank you. Benin government made the commitment in 2013 to expand access to voluntary family planning nationwide. And the APC supported the Ministry of Health to strengthen voluntary community-based access to injectable family planning, including access to injectables at community levels. There was support from the Mother and Child Health Directorates, but we have to conduct regular workshops, sessions with parliamentarians, with local elected, with journalists, with religious and local leaders, to bring them with us to be ready to accept the introduction of voluntary community-based family planning, including injectables. And while we do all this, we also held advocacy workshop to show them that the family planning, voluntary family planning is possible in Benin, because all of you know that Benin is a little bit conservative on family planning. And while we did all this one, we think that this engage all of them in the way of the benefit of voluntary family planning, and the approach contribute to successful results we have so far. Yeah.
You want to go next?
Okay. Yes. So we're talking about advocacy.
Yes.
Yes. So for APC in Uganda, as APC was starting out in 2014, one of the key advocacy issues that we found at the time was the need to start thinking how we bring private sector on board, particularly the drug shops into the fold of provision of injectable contraception, since there was already task sharing permitting community health workers to do that. But as mentioned earlier in other presentations, of course, the private sector is key, and they work longer hours, etc. So for APC Uganda, what we did at the time, we found that there had been pilots, there was evidence gathered, and then our role was now to synthesize all this and then engage the stakeholders. And we formed a task force with the drug shops, the FP injectables in drug shops task force. And we have coordinated that for the last 3 years. And by the end of 2017, both the senior management of the Ministry of Health and the National Drug Authority had authorized an extended implementation science activity in 20 districts to try out this practice. And this is being implemented right now. Yeah, and hopefully we'll share the results very soon.
Great.
Thank you.
Susan, what do you have for us?
For us, we engaged advocacy at 2 levels. We worked with the community members to really tell them that they had a voice in the health services that they were receiving or that they should expect from the government. So we brought them together with the nurses from the health facilities, and then the sub-county health leaders or health authorities, and engaged in dialogue. And so we told them what they were, what their services expect and the quality of the services. So they were like hands-on in the whether it's MCA service or family planning services. And then at the policy level, or let's say that at the county level, because back when I was in Ghana, we had a family planning program where the slogan was no product, no program. So if there are no commodities or there are no injections, services are hindered. So we also had advocacy activities with the Isiolo County government as well as the Garbatula County government that, we needed to have these materials available so that the services are not interrupted. So that's how we worked with the community. And we actually, so it involved training and actually one of the activities we took, one of the reproductive health coordinators to Uganda to Welshire to see the experience that they were doing, and they brought back some knowledge that they could use and improve their services. Thank you.
Thanks. Tanvi.
Perhaps just from the global perspective, APC did a lot of work in the advocacy space to support task shifting and task sharing, and so this is sort of speaking to Fred's role in Uganda as well as Jean's in Benin. There was a support and TA to countries not only to expand the product basket for family planning, but the variety of channels for which those family planning products could be accessed. And that happened in a variety of ways. And in some cases, it was expanding the scope of community health workers. And I don't think I can stress enough sort of the diversity around the types of community health workers that exist in countries, some formal, some not formal, various levels, so who can do what. And at the same time, again, the role of the private sector. And so there's also global work, global advocacy. I want to recognize John Standbeck from FHI, who's been hugely instrumental under APC to advocate for the role of drug shops and pharmacies at the global level and provide guidance around that. It's one thing to work with pharmacies that are often very highly trained, they're formalized. Not so much with drug shops. I mean, again, they're not even called drug shops in many countries. And so what does it really mean when we talk about task shifting for family planning with those particular cadre? And so we've been working both at country and global level to think through that.
Great. We still have a few minutes around this question if you want. I wonder if you all have thoughts, having heard from your colleagues, about what their example brings to the work that you were doing or brought to the work that you were doing, or more generally, how do you share across each other as you learn these things? Sorry, it wasn't a planned question.
Well, I think I will reiterate what I did say in my last response about our APC team here given that they were across countries. So when the headquarters team came to our project in Garbatula, they thought we could learn from Uganda, and so they facilitated that trip with workers from, World Vision staff from Garbatula, and we went to WellShare, and then, they learned so much about, social accountability, what we were doing in Garbatula, what they were doing in Uganda, and then we shared across how to improve quality and sustainability of some of the services, tax shifting, I think you said conservative, but Garbatula is also is a very traditional society, so some of the barriers had to be really broken, and I know our work involves, we really want a quick fix, but when you work in development, you can't. Sometimes it's a process to really get people to a comfortable place for them to take the baton and run with it. And so some of those are some of the lessons that, we picked up and shared. And we realized that we were not the only ones facing some of the challenges. It was nice to know that, other people were facing the same challenges, but, the solutions were out there, and that we just needed to go step by step to arrive at a solution that worked for the communities.
Thanks.
Okay, maybe for Uganda, what we have learned maybe across a range of things. First of all, in relation to the drug shops work, of course, when we were packaging the information, the justification paper, we used evidence from across the board, from everywhere. Work done by Save the Children, in partnership with FHI, with PATH, with other partners, because we had to really to show to the leaders in the ministry and the drug authority that there was global evidence to support this kind of thing. But we've continued to share through regional meetings. One of them is happening just next week in Nigeria, where 4 countries are meeting to again share about on the drug shops work and pharmacies. The other has been, we've been supporting the Ministry of Health to both to execute its family planning costed implementation plan with the support of several other partners, but there's been, of course, it's not very easy supporting government, and one of the things we did was to develop a performance tracking system, for which we've had challenges anchoring here and there, but then we benefited so much from the fact that APC Tanzania had done the same thing, and we got experience from them. We learned that some of the challenges they were facing were the same that we were facing, and we also really just adapted the system and modified it. So there's been a lot of cross-learning within the partnership. Many times we've had the same technical support for different organizations, but within countries. For instance, for us in Uganda, when we were starting the Christian Family Life Education curriculum, it was a bit of a challenge for FHI because we are not traditionally an organization that works with faith-based leaders, but APC, through Christian Connections for Family Health, was funding the Protestant Medical Bureau, and then we used them as our inroad. So they helped us get to the faith-based leaders and platforms within the districts where we have worked, and that has worked very well. Yes, thank you.
Okay. As I was saying, when Benin governments made the commitment to expand access to voluntary family planning, we discussed with the Directorate of Mother and Child Health, and we put in place a committee, a small technical committee, where we have the Ministry of Health representative, we have Midwife Association, and other partners working on family planning sector. And this committee used to meet frequently with all stakeholders to discuss the strategy we developed to expand voluntary family planning, including access to injectable at community level. And I think that was what we have done. The more important thing we have done that allow us to achieve the result that we have in 4 or 5 years of implementation.
Yeah. Thanks. Great, thank you. So the last question I thought maybe we could talk about as a group is thinking about sustainability and the journey to self-reliance. What are your thoughts about the next decade for family planning programming, and any advice you would want to put on the table about how we collectively think about how we go forward towards sustainability and self-reliance? Maybe I'll start again.
Okay.
Or me? Yeah. I think measurement is going to be really important. What is it that we're measuring, and working closely with not just government, but the NGOs or the private sector, whoever it is that we're going to be working with in country and partnering with country, that what are the common measures or standardized measurements around that? I think we've heard a lot today about the capacity of many of these local organizations, and what does it really mean, not just from an organizational capacity point of view, but technical capacity. At the global level, a lot of what we do is, we bring in a lot of that sort of global learning, what's happening at one country, and provide that learning to another country. And often when we're insular, we just don't often know maybe what's out there and what we can do. And that's an important function. And so how will that translate in the field as we think about building the capacity from not just an organizational point of view, but from a technical one as well? Thanks.
Okay. As for Benin, I think that in terms of family planning programming for the next decade, I think the Ministry of Health will strengthen its leadership and increase national financial resources for voluntary family planning, continue advocacy with donors and the government for regular supply of reproductive products, and allocate adequate funds to local governments and sign partnership with NGOs. I think when the Minister of Health will do all this assignment, if I can say that, Benin will be able to improve the contraceptive prevalence rates, which is still remain one of the lowest in the sub-region. That's what I think.
Okay, I think for Uganda, I would say that maybe we need to think of going a little bit beyond health, especially when we are engaging at the local level, at the local district level, because while at the national level we tend to work so much with the Ministry of Health and they have a reproductive health department, at the district level it's by design multi-sectoral. So you have the district health officer, you have the planner, etc. They are all headed by a chief administrative officer who is the accounting officer, but he is not health, and sometimes not even technical. But he has the powers to assign budget and all to determine what gets done in the area. So we need to be able to develop packages for engaging multi-sectorally at the local level, and supporting them to integrate family planning and reproductive health into all the other plans. Like in the example I gave in my speech, where because this district planner, who is the one that submits the plan and the budget and defends it in the council, came to 3 different meetings. One was about sharing data. The next one was for developing a plan. And then the other one, when I found him, he was in a meeting where now in the district they were giving feedback what they had learned from the other 2 meetings. And he was able to make a commitment that I'll make sure the budget has this. So you need to have, so he's not a health person. And so in that meeting he said, I'm now transformed. So, but I'm sure before, if the district health officer went to him with his plan, he would say, we have so many problems with the schools, please, you can first. But now he knows that probably if he doesn't address the issue of family planning, however much he builds so many schools, he will build until the sun comes back. But he will never meet the needs of the community. So we need to help get that buy-in and build the momentum from the local level beyond health. Yes.
Yeah. Thank you.
I think Fred said it well, and so I would agree with that. I think it should be country-led, systems, and it has just got to be planned in their annual planning statements and implementation plans. Yeah, because if there's not a line item, you tend to forget about it, and so that's what we have also been doing in some of our social accountability work with the members of county assemblies. So I totally agree with Fred. that
Great.
country engagement is the way to go.
Thank you. Thank you so much. So we now have about 20 minutes to take and try to answer questions from you all. So I think there are some roving mics. If people will put up their hands, we'll take 2 or 3 questions at once and then invite the panel to answer. If you have a specific person you want to have answer your question, please say so. Otherwise, we'll let panelists choose what they respond to. So I see somebody here in the orange, the gentleman in the orange shirt in the 4th row.
Thank you very much. I'm Mark Hathaway in the orange shirt from MCSP. I have a question that I guess is probably best directed to Tanvi about, you mentioned the diversity of community health workers across various countries and the range of skills and their incentives. And I'm curious if you can talk a little bit about how the learning goes on with them and how one can best train them up with a variety of different skills that they need to know and have, including the wide range of contraceptive methods that we now have available. So how can we ensure that the quality of training reaches them and it gets, in a way that's easily scaled up in various countries?
Okay. Is there another question? Yes, towards the back.
I'm Teresa Hope from FHI 360, and Susan, I heard you mention about the incorporation of food security into family planning programming, and then Frederick, you picked up on the theme of multi-sectoral solutions, and so maybe if you could talk more about in practical terms going forward, how a project like Advocacy or follow-on projects can stress multi-sectoral solutions.
Thank you. I can repeat it. Is there one more? Okay, we'll start with those 2. So just to repeat, a question around the diversity of health workers, the skills they have, the incentives that are provided to them. How does that learning happen? How can you ensure quality of training at scale in those very diverse situations? And then a second question around multi-sectoral solutions, connections between family planning and food security or other development activities. So Tanvi, you want to go first?
Thanks, Mark. First, that's a really tough question. So, as I'd mentioned earlier, when we embarked on creating this online database, it was very eye-opening, I think, for us to see how different systems and countries and terminology for community health workers varied country to country. In fact, I think at one point we were asked, could we create a paper to pull all of these things together to help standardize what that terminology looks like? And we couldn't. It'd be very top-down if we did that. And so at least we have now an online hub where we can see in country X that there may be 4 tiers to their community health workers. In other countries, there may be 2. For a while, I think a lot of folks were looking to Ethiopia as the gold standard and then said, you really need a lot of money to do that. And so to your question, I think, it really, I think, and this is probably not a surprise, but it's going to require, I think, a tailored approach and really looking at what those systems look like in country and what the policy allows in terms of what different cadre of community health workers can provide. And then based on that, how then do you scale up? But I don't think it's a one-size-fits-all answer, and I know that's probably cliche, but I've really been, I think, in fact, humbled by just, it's not even, and you think about language. I mean, depending on the country, there's such a variety and diversity in the scope of what these community health workers are allowed to do. And then there's some, of course, that are informal. So how do you bring them into the fold? And so I think it is really working at the local level to do that.
Susan and Fred, maybe on multi-sectoral?
Okay, thank you. Thank you for that question. So the idea that we had, or that why we heard the call to action from the community was that, as I said, Gamatula is really poor, and there's the place is arid, very dry. So when they came for MCH, maternal and child health clinics, we talked about nutrition and feeding and all that stuff. But then, how are they going to get that? So the idea is that if there was a way for them to have even consistent foods during the times when it was raining, and how even to preserve them, then they would have food round the year. So I think that in our work with USAID, sometimes we have funding from PEPFAR or the Population of Reproductive Health or maternal and child health. Is there a way to sort of have a program, a health program that has maybe an agricultural component, so that whilst we are telling them health is good, but then if I don't have money, how do I get to the health facility? That way, So I think maybe we can get creative and do it that way, because sometimes the streams are a bit set. In an example that I have outside, my work with World Vision, it was with an agricultural company. We were trying to talk about making the ground fertile, and so they needed to plant this year, this crop here, and that year, another crop here, to get the ground fertile. So if we have such a program, we can actually merge it with family planning, talking about birth spacing, and so we have to get creative in our work. So I'll hand it over to Fred.
Yes, thank you. So how we get the multi-sectoral solutions to work in practical terms? For APC Uganda, we have tested something that which I can share briefly. Is we realized that in this national strategy for family planning, the agency that was responsible for stewardship and also for promoting multi-sectoral engagement was the National Population Council. And so we brought them on board into the activity, and we wrote them into our plan this time. And so we kind of gave them an in-kind grant, because we can't fund government, but we've worked in partnership with the National Population Council to test models for multi-sectoral engagement at the local level in the 5 districts that we are currently implementing. And how that is, it includes several things. They did a mapping of who the multi-sectoral partners would be in each of the districts, and these were different for the different areas. So, for instance, one of the districts in the eastern region is Butaleja, is a rice-growing area, but has the highest adolescent pregnancy in the country, and partly the rice growing contributes to that, the trading and that business. So. For that area, we were very targeted. We made sure that the rice growing schemes were involved, and their structures. So they have savings groups and other groups, women's groups, the groups for planting, the groups for harvesting. So all these were brought in the fold. And then at the top level, the multi-sectoral working group in the district was formed with representatives from each of these groups. And these listening to evidence, we made sure everything we do, we start with them listening to the evidence. The NPC does the rapid modeling, the resource awareness package modeling for the local district, so that they get to understand that what contribution family planning can make to their different trades. And then after that, then we, at the local level, we did a family planning collaborative charter, which then brings together all these different groups, but now to the local level, and involving local leaders who make commitments, as small as, for instance, the local council chairman saying, I will make sure I organize 2 meetings where we'll discuss family planning. Yeah, something like that. But what we need to be cognizant of is that, of course, there are limited resources at the local level, and we need to think about how we would, within the limitations, support them to succeed, both resources and capacity, but also funding. Yeah, and how we think this can be sustained, because we are partnering directly with government institutions, both in our programming, in designing the program, And this institution, while APC might close, the National Population Council is there to stay, and they have to do, and now they have a model to work with, which we are documenting, and they can just look for any other funding source to support them to bring many other districts on board in this activity. Thank you so much.
Did you want to add anything? or-
Yeah.
Okay.
The multisectoral approach we use in Benin, which really worked, was at community level when we discussed with the Ministry of Health representative at district level, the Minister of Agriculture, Minister of Transport, and they have, all of them have the representative in a committee where we discuss frequently on specific aspect on community health, and particularly on voluntary family planning issues. And when this committee discuss and find a way to address a problem or a concern on community health in general, these issues have been gave to the mayors, who is the leader, who have the lead of this committee, to find, to seek for money or other resources to address these issues. Is what I want to add.
Thank you.
Yeah.
Okay, back to you all. In the back on the aisle, forward here 2 rows, and over to the woman in the 4th row. And then we'll come back to you.
Good morning. Thank you so much for the panelists for a great presentation. My name is Elsa Barhane, and I'm with World Vision. And mine is a comment, but maybe I'm willing to hear from the panelists what they think. You know, we talk about sustainability and self-reliance. Many of these places, what you guys are talking about in terms of Garbatula, Benin, I really wonder if these communities are thinking of the self-reliance and sustainability, they're thinking of survival. And I think I think ultimately we want to see that as like the ultimate goal, but I really, really doubt if these communities are going to be self-reliant soon, or they're going to be, any of these programs will be sustainable, because if you're talking about Garbatula, these are nomadic, they're facing a lot of climatic challenges, they're facing a lot of political, sustainability,
Instability.
conflicts, conflict zone, etc. And I was recently in Ethiopia visiting a WASH project, and I was just struck at the amount of, we talk about the SDGs and for WASH. I'm giving you just an example. I said these people are talking about just getting water on a daily basis. I'm not going to be talking about sustainability. I'm not going to be talking about self-reliance. So for me, this is just a reflection to be a bit realistic. As someone that grew up in Africa and, realizing all the challenges that we're facing on a daily basis, talking about reliance and long-term sustainability might not be the case in many places right now. I think we need to look for a longer plan about where we can, like a road for them towards sustainability and self-reliance.
Thank you.
Just my thinking.
Actually, my question dovetails well with that one. Thinking about a context like Yemen, for example, where the system is collapsed and the communities are, to some extent, having to be self-reliant. There's no funding coming to pay anybody, let alone incentives at the community level. What would you recommend that we do in a setting like that to, maybe we can't think about sustainability, but how do we work in a system where we're not going to be necessarily engaging with the authorities that will be there in the long run? And what can we do in the meantime to think about connecting the community who is actually the level that's responding during the conflict the very most to survive?
Thanks. And I think up here on this side, there you go.
Thank you. My name is Carrie Dobies, and I work at IMA World Health, but was on APC for about 3 years working with Sean and the post-Ebola teams. So this question is especially for Jean, but if anyone else on the panel has thoughts on that, that would be welcomed. Regarding the grants that were issued, I know in Benin, with the PIHI grantees, they were directly funded by USAID and technically and in some ways capacity building wise supported by APC. You spoke about the advantages of that, but could you speak a little bit about if there were any disadvantages that you see, and for other panelists, if it was managed differently, what you think are either advantages or disadvantages of that approach to issuing grants?
Thanks. So 2 comments, questions around sustainability, sort of the journey to self-reliance, the idea that countries are not all at the top end here, and many of them have a very long way to go, and how do we think about this differently at different points along there, and particularly around fragile settings where the community may be the constant over time in a changing political landscape. And then a somewhat separate question about the disadvantages of the lack of direct funding. So on sort of the journey that is self-reliance and differential approaches. Anybody?
Thank you, Elsa from World Vision, my colleague. I think, and I like, Ellen, your comment about the fact that various countries or communities are at different stages on that journey to self-reliance or sustainability. But I think that we need to continue to work in those communities. And that's why I think that community health is so important, because the community folk are going to be there. Even if they move into IDPs or into refugee camps, they are the people. So I think if we give them some skills on how to survive, as you had put it, on how to get along day by day to find, things to keep them alive and healthy, I think that is what we can do in terms as they move from one point to the other. Other than that, I think I'm going to leave it to hear some ideas from some of my other colleagues, but we can't stop. As I said, when we're working in Garbatula, we faced gunfire, we faced travel conflict, but we stayed and continued to provide the service because they needed it. So I think that's, we need to continue to give them the skills and move on a day-to-day basis. Thank you.
Okay, and Susan addresses the community part of it very well, so I'll go to the higher tier, which is, of course, to the communities, as much as the communities are thinking about survival, the leadership of the community also thinks about the same. And that's why, again, going beyond health. So you have to be able to understand what are their other needs, but again, help them understand what the contribution that the family planning or whatever other reproductive health intervention you're doing is going to make so that their other problems are not, blown up. So we still have to engage the local leaderships, get their buy-in. Many times they're the ones who receive the resources and will abuse them and do not prioritize the areas that might matter to the women or to the children. So I think that's still critical, however fragile the situation might be. I think I faced the same in northern Uganda when there was conflict, and still you thought you could do nothing. But there are very many things that we did which now have actually made some of their indicators do better than other areas where there was no war. So I think there's still things we can do in that fragile environment. And of course it is a long journey. I think it works like the district I mentioned, Agago. We've been there for 5 years. Fortunately for them, the hotspot mapping took us back to them because we were there previously, and again they were selected through the data. And I think because of the longer engagement and trying different approaches, they are now beginning to get there. Great. Yes. Yeah.
Jean, maybe you could address particularly this question around some of the disadvantages of not providing direct funding to local organizations.
Okay. Thank you, Ms. Idovi, for this question. I think that it's not easy to assist somebody or an institution when you don't handle the budget they have. And our main difficulty on this assistance is when we are coaching them to develop their work plan. We propose activities, but we don't know exactly how many they budget in the grants. So sometimes we are hoping that they can propose activities in a certain range, but they told us that we don't have this money in our budget submitted to USAID. So we were always we were not able to give them the support we would like to give. So this is the big disadvantage we have on this manner to grant NGOs without APC's control. Yeah.
Thanks very much. So I think we can probably take 2 more questions if they're quick, and if the answers are quick. I think I saw John's hand up earlier, and the woman in the red suit on the aisle. Yes, you. Go ahead.
Thank you very much. I'm John Stanback from FHI 360. Thank you all for those great presentations, and it was great to hear how you've made use of strong partnerships to further your programs. When I think about task sharing and task shifting, which you all have talked about, I sometimes contrast it with interventions, other kinds of interventions like quality improvement or training or even multi-sectoral interventions, because with those sorts of things, you're always bringing new resources to communities and to stakeholders. But sometimes task sharing is perceived as taking away from somebody's turf or status or even their income. So, and not just for family planning. So when community health workers start doing antenatal care, the Professional Nursing Association might object, and physician associations object when midwives start being trained to insert implants, and the local pharmaceuticals professional association is unhappy if drug shops start providing contraceptives. So my question to you is how you have used partnerships to sort of overcome these objections at local levels that can slow down programs and keep them from being effective. Thank you.
Thank you. And one last question on the aisle, 3 rows back.
Good morning. I'm Annie Wilderman, founder and CEO of SemiAce, that's collaborative engagements on matters of mutual interest, agents of change empowered. I have been lucky enough to have been trained by USAID on academic and conceptualization and implementation of projects funded by USAID. My question is, have you defined and or developed metrics by what you mean by sustainability? Why do I ask that, okay? Sustainability, to me, is a matter of debate. You don't go to a foreign country like the Philippines and aim to go out there that we are 100% sustainable. Otherwise, the project is already a failed project. To me, sustainability is our ability to empower the recipient of our aid to want to be sustainable, to work to be sustainable. And if they don't know what that means, help them define it. Thank you.
Thank you. Okay, John's question about how, particularly around task shifting, can we make it a win-win? And then this notion of what is sustainability, who defines sustainability, how do you engage people in that journey themselves? So on maybe Tanvi on task shifting?
Sure. So, John, certainly speaking with some of the dynamics that you've talked about, particularly between private sector, public sector, even within private sector, drug shops and pharmacies is an issue. So part of the rationale for us bringing that co-design aspect to our work was, could we sort of break down some of the perceptions, the assumptions, and have a healthy debate? And we did that in many instances. Did it solve everything? No, but I do think it created a new awareness and an understanding, at least I hope, around what the respective roles are and what the shared value is. One example I'll quickly give, just recently in Zambia, is when we were talking about introducing Cyanopress in pharmacies. One of the higher-ups in the Ministry of Health, his one concern was, well, what if there's a long lineup? Will that pharmacist be able to provide the service? And the rest of us were sort of thinking, well, is there a real long lineup in the Ministry of Health? And, couldn't this help offload some of that? And it's a private sector, and maybe they'll figure it out. So it was an interesting sentiment that was expressed, but it allowed us to really have a conversation about it. So there's not a single answer to that question, but I think and I hope that through our work that we're working on it.
And then maybe around sort of harnessing people's dreams for themselves towards sustainability. Anybody?
I think I would have wanted to share about
Go ahead,
just
please.
sharing a little
As-
bit
as
more
you wish. Go ahead.
based on my experience, because the task force that we had for the drug shops in Uganda we engaged several stakeholders in consultations, and of course one thing that I saw that was helpful was at every stage you make sure you get to understand their concerns and fears and document them, and then have a dialogue and propose solutions at every step, so that you are appealing to their emotions, their intellect and ethics at every step you're going. And so kind of that is what I felt kind of what, because the different stakeholders have to understand that this is coming in partnership and not in competition. Yes. Yeah. So the issue of sustainability metrics, I think I leave it to you.
I agree. I suppose that's completely fair. So I think certainly we recognize that what we're talking about is a journey, but we also recognize that people have dreams for themselves, and what this is about is helping them achieve those dreams. There are metrics associated with the journey to self-reliance. They're available on the USAID website. They're principally around capacity building and commitment in different sectors, economically, politically, voice, as well as technical areas. They're at a fairly high level, and they need to be brought down to some lower levels as well. But if you listen to Mark Green talk about it, it really is about people want to be able to do this themselves. They care about their own country, their own setting. They're not looking for a handout. They're looking to be participants in strengthening their own countries. And I think what we've talked about here today around partnership and the engagement of the community, how you bring issues forward to groups like mayors, what it takes to engage with the faith sector, the use of data, the strong local support, the inclusion of different communities, different sectors at the community level, and global advocacy. Those are all really important along this path for family planning, but also more broadly than family planning. So the next panel after the break is going to look at another side of this, which is advancing local solutions for lasting impact and building capacity of local partner organizations in the areas of financing and sustainability. But what I'd like to do now is thank these panelists very much for their TED Talks.